Hello everyone, David Wilson here from Dr. Stem Cells and another video on the American Academy of Orthopedic Surgeons and their technology review for PRP. This is a very useful tool. They summarize a lot of very interesting data. So we're just going to scroll down here to the next section, which is PRP versus other drugs, non-steroidal anti-inflammatories in particular, and then they've said celecoxib and acetaminophen. This is a very interesting topic to discuss because, as we have discussed in a previous video, we have to think about how the body is affected by drugs and how they might affect platelets, the healing cascade, among other things. So if we were to look now over to this document, we've already looked at this in our last article where we discussed the effects of corticosteroids on healing. The same thing will be relevant in this case. Now we're going to do a deep dive on the complement and the wound healing cascade. That'll be a different video where we go more in depth of this study. But let's take a quick look at this table because there's a lot of interesting data here that we should discuss. You can see that you have injury, clotting cascade, tissue injury, thromboxane A2, prostaglandin F2 alpha, all from the tissue injury itself, resulting in platelet effect. The clotting cascade should target platelets, cause them to be activated. Well, then what happens with the platelets? The platelets will then encourage complement C5, EGF, and all these other factors to start getting involved. Now, again, similar to corticosteroid injections, non-steroidal anti-inflammatories inhibit the COX activation, where the platelet will have generation of arachidonic acid down the pathway to prostaglandins. When you inhibit that cyclooxygenase at the COX pathway, the platelets are actually affected, and if they're on non-steroidal anti-inflammatories, patients who are on non-steroidal anti-inflammatories will have a reduced effect of their platelets. So PRP is not recommended to patients who are on anti-inflammatories at the same time. They should have a break, preferably a week, at least 3 to 4 days, longer if possible, so that their platelets have actually metabolized and removed the effect of, and the blocking effect of that non-steroidal anti-inflammatory on the COX pathway. So back to our discussion, the anti-inflammatories then will affect this section and down. So anti-inflammatories cause reduction in prostaglandin, reduction in swelling, reduction in pain, reduction in local irritation, and that is why they have such a beneficial and considered so beneficial for patients, because of course if you can reduce pain, reduce swelling, give people more function back, they can live better, they have better quality of life, they'll have better pain scores, and they'll be their better outlook in general. So there are 2 high quality studies that looked at this, 3 moderate quality studies in 2016, 2019, 2020, and they were included and considered. They have looked at PRP and NSAIDs directly, or acetaminophen, which is also paracetamol, for osteoarthritis. The 2 high quality studies evaluated outcome in 120 patients, and we're rounding up as you can see, and the PRP showed statistically significant improvement compared to NSAIDs or acetaminophen for the VAS pain score in all studies that looked at it. WOMAC composite scores were also better for PRP than NSAIDs, and WOMAC function scores were also better with PRP at 6 months, 3, 6, and 12 months. Collectively, PRP showed statistically significant improvement in several patient-reported outcomes when compared to oral NSAIDs or acetaminophen for patients with osteoarthritis of the knee. However, consideration should be given to limited sample size, blinding strategies, and small number of published studies which meet the inclusion criteria. Additional research comparing the use of PRP to NSAIDs may yield more clarity. Again, very well summarized. We need more research in the field, but we can start to talk about why we think this is the way it is based on what we have seen already. Now, as we've already discussed, PRP is concentrated platelets. It's platelets in plasma. Some people give it leukocyte rich, others give it leukocyte poor. That means that in some cases you filter away the white blood cells, in other cases you leave them in. For the sake of this part of the discussion, that's not really relevant. What is relevant here is that non-steroidal anti-inflammatories, because they break off platelet activation, they stop that chain. So you can imagine you have a big chain of chemical commands that have to be followed for the body to really get into its healing phase. Because NSAIDs break that chain early, up quite high, not quite as high as your corticosteroid injections, but pretty high up, they're pretty close. They inhibit the cyclooxygenase pathway, and in so doing, they prevent platelets from really getting active. What we know that means is that as platelets are then prevented from their activity, they're stopped from going down this healing pathway, this cascade, you actually will end up with the longer term use of non-steroidal anti-inflammatories will actually impair your body's ability to have this normal healing cascade. We have seen reports, and you can see it especially if you look up the lower back pain scores. There was a new study released not long ago which said that using NSAIDs in the first 6 weeks of injury actually increases your chance of going from an acute lower back pain to a chronic lower back pain. And that makes sense because you're actually inhibiting the healing cascade as it goes. Now, in this case, these patients have chronic established osteoarthritis. The difference here then is that they're taking their anti-inflammatories to keep inflammation down so they can function. And that is absolutely a justifiable choice. For patients who have and feel like they've got to the stage where their quality of life is starting to fall, to give them NSAIDs is absolutely justifiable. It's something that will make their life quality better, hopefully give them more movement, more function, and overall better quality of life. On the other hand, PRP, as we look at it, must be used separate to and never in conjunction with NSAIDs because they will interfere with each other. Primarily the NSAIDs will actually just give a very poor outcome for your PRP because they inhibit the platelet activation. However, there is slightly more to discuss in this topic as well. We have to also consider side effects. Patients who are on NSAIDs are going to have all of the NSAID side effects. We know that NSAIDs can cause kidney failure, they can cause cardiac damage, they can cause gastrointestinal bleeding, among other things. Because of this, for some patients, NSAIDs are not going to be an option, and for other patients, they're going to be an option to be used in limited quantities for a limited period of time. At this point, I think you then start to see that there is definitely a crossover where PRP becomes more and more attractive for the patient who wants to have try something. It's natural, it's from their own body, for their body, so because it's autologous, there is very little risk. They can't really have any strange or startling consequences. As long as the injection is performed correctly and it goes to the right place, it should stimulate some response. This being the case, then, I think you can make a good argument that PRP is at least worthy of consideration when you start to look at longer term NSAID use. The final point of discussion then in this particular case would be to look at the cost of PRP, and that will depend on where you are and what type of PRP kits are being used against the ongoing cost of NSAIDs, and that's something that has to be discussed in a case-by-case basis with the patient. In my opinion, patients can absolutely use NSAIDs for short-term relief, looking for short to medium-term effects, but once you start to consider long-term, I definitely would be recommending pushing towards PRP to try and encourage patients to try that out and see if they can get some relief. I hope this has been useful and you've felt that you learned something. Leave comments or questions down below. I'll try and get back to you. I'll put my glasses back on now, even though we've all the reflections of the day here. So thanks for joining me. We'll see you in the next video, and I think the next video we're going to do will be PRP versus ozone.